Welcome to the Depth Dive. Today, we're really going deep. Forget just LepDub. We're aiming to decode the heart's own language. You know, the sounds, the timing, the pressures, how it tells us what's going on inside. We've pulled together a lot of material on this hemodynamics, heart sounds S1 through S4, clicks, snaps, that kind of thing, S2 splitting too, and also how to read the jugular venous pressure, the JVP. Basically, our mission here is to connect all these clues, these sounds and pressures, directly back to the why. Is it a volume problem? Is it a pressure problem? We want to give you those high-impact concepts, maybe some useful mnemonics, so you can piece it together quickly. Okay, let's dive in. Where better to start than the basics? S1 and S2.
Absolutely. S1. That's your first heart sound. It's the sound of the mitral and tricuspid valves, the AV valves, closing. And crucially, it marks the start of systole. You'll hear it best down at the apex.
Right, the apex. And it's not just hearing it, is it? The intensity matters. A loud S1, for instance. Why does that point towards something like mitral stenosis?
Well, think about the mechanics. Mitral stenosis means a narrowed, kind of stiff valve. So when the ventricle contracts, it slams that valve shut really hard, makes a loud, sharp sound. Or another cause is a short PR interval on the ECG.
How does that cause a loud S1?
Because the valves are still wide open when the ventricle starts squeezing. So again, they snap shut forcefully. Loud sound.
Okay. And the opposite, a soft S1.
That suggests the valves aren't closing properly. Maybe mitral regurgitation where they leak, or if the PR interval is long, the leaflets kind of drift closed before the main contraction, so there's less force, less sound, no real snap.
Makes sense. So S1 starts systole, S2 then marks the end.
Exactly. S2 is the closure of the semilunar valves, the aortic, A2, and pulmonic, P2, marks the end of systole, beginning of diastole. You listen for S2 more towards the base of the heart, left upper sternal border usually.
And intensity clues here too.
Definitely. A loud A2, that aortic component, makes you think systemic hypertension. High pressure in the aorta, slamming that valve shut.
And then loud.
Later two, that points towards pulmonary hypertension. Same idea, high pressure in the pulmonary artery. The sound level tells you about the pressure.
Okay, foundation laid. Now this is where I think it gets really interesting, the extra sounds, S3 and S4, these gallops. For anyone listening, these are like diagnostic shortcuts, right? Straight to volume versus pressure overload.
That's a great way to put it, fast clues. Let's take S3 first. That's the volume sound. People call it the Kentucky Gallop. You hear S1, S2, S3. It happens right after S2 in early diastole.
And there's a mnemonic. S3 equals CUB.
Yeah, CUBE for volume overload. Helps you remember the mechanism. The sound comes from blood rushing rapidly, passively into a ventricle that's either super compliant or more often pathologically, it's dilated. Stretched out from too much volume. Imagine pouring water into a big floppy bag. It makes a low thudding sound. That's kind of like S3. The vibration of that filling.
So in adults, hearing an S3 usually means?
Bad news generally. Systolic heart failure is classic. Also, mitral regurgitation, dilated cardiomyopathy, conditions where the ventricle is failing and dilated.
But it's not always bad, right? I remember learning about physiologic S3s in kids, athletes, pregnant women.
That's true, and it's a key point. Young, healthy hearts or hearts working in a high output state like pregnancy can be very compliant, and you might hear a faint S3. It's usually softer, higher pitched. The pathologic S3 in heart failure is typically lower pitched, maybe easier to hear, and importantly, it comes with other signs like shortness of breath, edema.
So context is everything. An S3 in a patient with symptoms is almost certainly pathology.
Exactly. You have to assume it's significant until you prove otherwise in an adult with symptoms.
Okay, so S3 is the CUBE volume overload. Let's contrast that with S4, the pressure sound.
Right. S4 is the Tennessee rhythm. S4, S1, S2. Notice it comes before S1 in late diastole. And if S3 was the CUBE, S4 is the PUH.
The PUSH, signifying pressure overload. What's the mechanism here? If S3 was passive filling.
S4 is active. It's the sound of the atrium contracting the atrial kick, trying to push that last bit of blood into a ventricle that's stiff, non-compliant. The ventricle just doesn't want to stretch anymore. It resists that final push.
So the stiffness causes the sound, the atrium pushing against a wall.
Precisely. And that stiffness usually comes from chronic pressure problems. Think left ventricular hypertrophy, or LVH, maybe from long-term high blood pressure, or severe aortic stenosis where the ventricle thickens to overcome the valve. Ischemic heart disease can also cause stiffness. And unlike S3, an S4 in an adult is pretty much always pathologic.
Always pathologic. And one really key diagnostic pearl, S4 disappears in atrial fibrillation.
Correct. AFib means no organized atrial contraction, no atrial kick. No kick means no PUSH against the stiff ventricle, therefore no S4 sound. It's a simple but powerful clue. If you hear an S4, you know the patient is not an AFib at that moment.
Okay, fascinating. So we have the basic sounds, the gallops telling us volume versus pressure. What about S2 splitting? That feels like timing the ventricles against each other.
That's exactly what it is. You're listening to the slight difference in timing between the aortic valve closing, A2, and the pulmonic valve closing, P2. Normally there's a little split that widens slightly when you breathe in. That's physiologic splitting.
Why does breathing in cause that?
Inspiration increases venous return to the right side of the heart. More blood takes slightly longer for the right ventricle to eject. So the pulmonic valve, P2, closes a tiny bit later than A2 during inspiration. On expiration, they close almost together. That's normal.
Got it. But then there are the abnormal patterns, wide splitting.
Wide splitting means P2 is just always delayed. The split is there during expiration and gets even wider during inspiration. Think delayed right ventricular emptying, maybe a right bundle branch block slowing down RV contraction, or pulmonic stenosis making it harder to eject blood.
Okay, and then the classic one, fixed splitting.
Yes, fixed splitting. The split between A2 and P2 is there, and it doesn't change with breathing. It stays the same width. This is basically pathognomonic, the dead giveaway, for an atrial septal defect, an ASD.
Why does an ASD cause that?
Because there's a constant flow of blood from the left atrium to the right atrium through the hole. This constantly overloads the right ventricle with volume. So the RV always takes longer to empty. P2 is always delayed, regardless of breathing. Fixed delay, fixed split.
Makes sense. And the last one sounds confusing. Paradoxical splitting. Reversed.
Yeah, paradoxical or reverse splitting flips the script. Here, the aortic valve, A2, is the one that's delayed. It closes after P2. So the split actually appears on expiration and disappears on inspiration, the opposite of normal. This tells you there's delayed left ventricular emptying. Think left bundle branch block, or severe aortic stenosis delaying LV ejection.
Wow, okay. So just listening to how S2 behaves with breathing gives you incredible clues about conduction and valve problems. All right, let's shift gears a bit. Dynamic auscultation, making the heart talk by changing conditions on the fly.
Right. Using maneuvers to change, preload the volume coming back to the heart or afterload the resistance the heart pumps against. This changes murmur intensity. Generally, most murmurs get louder if you increase flow across the valve. So increasing preload or afterload usually makes murmurs like aortic stenosis or mitral regurgitation louder.
But there are always exceptions in cardiology, aren't there?
Yeah.
Hypertrophic cardiomyopathy, HCM, and mitral valve prolapse, MVP, they seem backwards.
They are. They're the big exceptions everyone needs to know. Let's take HCM first. HCM involves a thickened septum that can obstruct outflow from the left ventricle. If you decrease preload, make the patient stand up quickly, or do a Valsalva.
Less volume in the ventricle.
Exactly. Less volume makes the chamber smaller, the walls get closer together, and that outflow obstruction actually gets worse. So the HCM murmur gets louder when preload decreases.
Totally counterintuitive. Less blood, louder murmur.
Okay.
And MVP.
Mitral valve prolapse. Similar idea with volume. When you decrease LV volume by standing or Valsalva, the mitral leaflets prolapse back into the atrium earlier in systole. So the characteristic MVP click happens sooner. Conversely, if you increase preload and afterload, make the patient squat or grip their hands hard.
More volume, bigger chamber.
Right. Bigger chamber decreases the HCM obstruction, so the murmur gets softer. And for MVP, the click happens later in systole because the larger volume supports the leaflets better.
So HCM and MVP murmurs get softer with maneuvers that increase volume, while most others get louder. Key distinction.
Absolutely key. And one more quick maneuver point. The Carvalho sign for telling right-sided from left-sided murmurs?
Ah, yes. Inspiration helps the right side.
Correct. Breathing in increases venous return to the right heart. So right-sided murmurs, like tricuspid regurgitation, will get noticeably louder during inspiration, helps you localize the problem.
Perfect. Okay, last big piece of the puzzle. Looking at pressure via the jugular venous pressure, the JVP, our window into the right heart.
Exactly. The JVP in the neck veins gives you a pretty good estimate of right atrial pressure, RAP. And RAP, in turn, is a good estimate of how full the right ventricle is at the end of filling the right ventricular end diastolic pressure, RVEDP. It's a non-invasive preload assessment.
And we're looking at those pulsations, the waves, A, C, and V. How do they line up with the heart sounds in ECG?
Okay, the A wave. That's atrial contraction, the atrial kick pushing blood into the RV. It happens just before S1 and lines up with the P wave on the ECG. If you see a really prominent A wave, a giant A wave, it means the right atrium is struggling. contracting hard against resistance.
Like against a stiff RV.
Exactly.
Right.
Maybe from pulmonary hypertension, making the RV stiff, or from tricuspid stenosis, narrowing the valve. High resistance causes a big A wave.
Okay. Then the C wave.
The C wave is usually smaller. It happens around S1 during early systole near the QRS complex. It's thought to be the tricuspid valve just bulging back a bit into the right atrium as the ventricle contracts.
Not usually the main event then. The V wave seems more diagnostically important.
Oh, definitely. The V wave happens later in systole, near S2 and the T wave. It reflects passive filling of the right atrium while the tricuspid valve is closed. Blood is returning from the body. But if you see a giant V wave, sometimes called a cannon V wave.
That's the money sign for tricuspid regurgitation?
Absolutely. It means during systole, blood isn't just passively filling the RA, it's actively shooting backwards from the RV through the leaky tricuspid valve. That creates a huge pressure wave, a giant V wave. Very specific sign.
Got it. And what about the dips, the descents? The Y descent seems key.
Right, the Y descent follows the V wave. It represents the rapid, passive emptying of the right atrium into the right ventricle when the tricuspid valve opens in early diastole. If that U descent is slow or blunted, it means the RV isn't filling well. Think cardiac tamponade, the heart is being squeezed, restricting filling. But if you see a really sharp, steep Y descent followed by a sudden stop.
Like the blood rushes in fast and hits a wall.
Exactly. That's called Kussmaul sign, often seen with the prominent Maudit descent, and it's characteristic of constrictive pericarditis. The rigid pericardium allows rapid early filling, but then it just abruptly stops the ventricle from expanding further.
Wow. Okay, so we've gone from the basic lub-dub through the gallops, the splitting, the maneuvers, and now the JVP waves. It really paints a detailed picture.
It does. And if you just remember those core contrasts, S3 Kentucky, for volume overload, the CUBE, think systolic failure, versus S4 Tennessee for pressure overload, the PUSH, think diastolic failure or stiffness. That's a huge chunk of the diagnostic process right there.
That's incredibly helpful.
And thinking about the JVP, we're reflecting that pressure up the superior vena cava, the SVC. And it leads to a final thought. When someone has severe right heart failure, they're volume overloaded. Both the SVC system, which gives us the JVP in the neck, and the inferior vena cava system, the IVC, are congested. But they manifest differently, don't they?
Ah, right. There's that mnemonic. SEC shows, IVC stores.
Exactly. Why is that distinction so vital clinically? What's the difference between what the SVC shows and what the IVC stores?
Well, the SVC shows the pressure directly. You can see the elevated JVP. You can see the waveforms if you look closely. It's a visible pressure gauge.
Precisely. And the IVC?
The IVC system stores that excess volume. That's where you see the consequences. Lower down, the liver gets congested and enlarged. Hepatomegaly. You might see ascites, fluid in the belly, and of course the peripheral edema in the legs and feet.
Perfect. So the SVC shows the pressure. The IVC stores the volume, leading to those physical signs of congestion. Understanding both is key to assessing just how overloaded your patient is.
That's a fantastic point to end on. It brings the pressure readings right back to the patient's bedside findings. Thank you so much for walking us through all that. This has been incredibly insightful, and thank you all for joining us on this deep dive. Hopefully you feel better equipped to decode the subtle but vital language of the heart. Keep listening, keep learning.